Thank you, Manos, for having me here, not only in the battles, fighting situations, also in the calm talk discussion rounds. We'll hear a couple of talks, and my duty was to give some considerations for the treatment algorithm. I tried to perhaps show you more on the conservative side because the later talks will go more on the surgical side. Well, let's start this up. Should we do any surgery on AC joint instability at all? If we look at the reviews and also the reviews we have done with our groups, you can see that basically there are similar outcomes for surgical versus conservative treatments. With surgical treatments, there seems to be less pain. Of course, with the surgeries, as we have heard nicely in the last sessions, with surgery, you get complications. With no surgery, you don't get complications. And of course, you can only get a rate of recurrence with surgery, which is about 15–40% overall. When seeing this data, it's hard to argue against the evidence, but in fact, I do see patients who have problems with chronically unstable AC joints. And this is one patient, it's a 20-year-old tennis player, and his problem was clicking of his joint when he played tennis. And when you look at his, I have patient-reported outcomes for my patients with the heartbeat system, and this is the ASES score of this patient. And the first score with 92 is before surgery. This guy had a significant problem, and he has an ISES score of 92. So you're pretty crazy to do surgery on someone who has an ASES score of 92. But we solved this problem. But you see, when we use our common scores, like the constant score, ASES score, perhaps we don't pick these patients who have problems with the AC joint. Factors for successful surgeries to somehow orient in between all these Rockwood types. I think the two topics I want to talk about is our diagnostic accuracy and the finding of the correct indication. First step, where's the crater instability? These are the general pictures you get from your emergency room department when you just have an AP view of the shoulder and you see these two and you think which one is the one with the higher instability. So this is a plethora for me to go for a bilateral view because this enables us to have an objective measurement of the CC distance of both shoulders if you had not an injury on the other side like a couple of my bicycle riders have. But here you see this picture, which looked in the basic AP view not so much, has a much higher instability grade, which is a type 5. And the other one, which looked much more disastrous, has not so much AC distance. And in these situations, especially in the chronics, an Alexander view is helpful to really show this overriding of the lateral clavicle, which means that this is a kind of type 3 dynamic instability or type 4 more dynamic horizontal instability type. So we looked this up in the literature. Again, here also we have no gold standard, but there seems to be a consensus that when you use bilateral AP or Sanka views, you have an objective measurement of the CC distance. And when you use right now the Alexander stress views, you have a possibility to pick up the horizontal instabilities. There are different ways coming up. Byrne Group is doing the AC/DC scores and different very sophisticated measurements, but I think these are very pragmatic ways to counsel your patients in the all-day setting. And the next thing is finding the correct indication, not only based on the X-ray. And here you see the scapulo-thoracic motion. That's the problem these patients have. And basically, that's all this AC joint is about. Greg Bain has made up this very nice force couple of the shoulder, where we know this triangle of the force couple of the glenohumeral joint. And we have kind of a comparable force couple with our AC joint. We have in the anterior and front, we have the clavicular arch with an intact AC and SC joint. In the back, we have the muscle of the scapula, thoracic motion, and we have the trunk. And if this does not work closely together, you have this instability as you have seen it in this video. And we know from biomechanical studies that the clavicle has a strut function for the AC joint and for the function of the upper extremity. And in this biomechanical study by Oki, he has shown that the problem is especially in the abducted, internally rotated arm. And this is exactly the motion when the strut function is very important and when the acromion underwrites under the lateral clavicle. And horses don't need this motion. They don't have a clavicle. They have just the pendulum motion. And as humans, we need our big motion of our arms in the 360 degrees or 180 degrees, and we need this function. And when you go to German cars, you see what this strut is about. And it's in the car, in between the wheels in the front. This is a car without a strut, and you have a racing car with a strut. And this prohibits this pushing together and making your car faster and more stable. And here again, you see the scapulothoracic motion of this patient when the acromion, because of the pectoralis, because of the front muscle, goes underneath the lateral clavicle. Kepler described it. We have force problems if the scapula is not stable, and we have problems with getting loads on our shoulder. And this has also been shown in studies by the Italian groups that patients who have problems with instability of the AC joint are patients who have problems in properly moving their scapula, so have scapular dyskinesis. And these are the patients who have less scores. And on the other hand, if we manage to get their scapula back again in good motion, then we have the key to solve this problem for these patients. And in a lot of patients, you can do this just by physiotherapy. And we know that there's a certain amount of time, which is seems to be 6 weeks, that when they profit within that time with their motion, then you have made your win and you have solved the problem for the patient. There seems to be a cutoff that if you go longer with treatment, there seems to be no benefit anymore. So perhaps this helps us to decide and counsel our patients if we have this 5 to 6 weeks block, and then we can make a decision. And of course, conservative treatment for the AC joint is not just having a sling, go home and take pills. It is trying to get this scapular motion back again. Gus Mazzocca has put out a rehabilitation protocol, and I personally try to work with these protocols by Ann Kuhls and Alan Becker, who really give you the ways of how to train your scapular motion. This is a patient conservatively treated, a type 3 instability, and he was coping his scapula and so successful. And the overall question when we see these very good results for conservative treatments is, do we lose anything afterwards? And as well as our group from Connecticut, together with Gus Mazzocca, we could show that if you go later on in a surgical procedure, you gain the same results. And basically the same thing was seen by Pete Millett group. So one important message is, don't be hectic when there's an AC joint instability. Don't hurry. This is nothing you have to do surgery in a 24-hour time frame. Make a good decision with your patient and try to figure out the components. So for the decision making for me, I try to use this edition of the Rockwood classification, which we published together with the ISACOS Upper Extremity Committee, which is now 10 years revival. And we have learned that it's not only looking at the imaging, it's also trying to understand the function of the patient, trying to pick these patients who are not able to cope with their scapula. And in addition on this, imaging, scapular motion, re-evaluation of the patient, I also switched to a kind of a risk stratification of my patients. Because we know that heavy manual workers, overhead athletes, are rather more the ones who might have problems later on with an instability of the AC joint. This is what we find when we look at our chronic instability patients. I rather see very few females. I rather see very few not overhead athletes, not heavy workloaders who report later on with a chronic instability. If I see someone with a chronic instability, it's rather these type males with overhead activities or with heavy loads. And also if you have contact athlete like an ice hockey player, he will crash into the wall about 3 weeks after you did your surgery, and he's only doing sports below the horizontal line. So he will not have problems with an instability of the AC joint. So for me, this is low risk patients. I rather go not surgically with these, with the higher risk patients, together with our ideas of the consensus. I try to counsel the patient accordingly. And when it turns out to go for surgery, for me, it's more the development to stay simple and stay anatomic. I try to have one technique for the acute and the chronic settings. I only add the tendon to this. Then we have a hybrid technique. I don't think that we need very different techniques in the acute to very different specific techniques in the chronic. Try to be anatomic, try to use the principles we have with less bone holes, we will hear it later on, to make your technique. And this in summary is for the acute instability. Type 1 and type 3 is absolutely conservative treatment for me. In a type 4, type 5, where I see the more than 100% distance, they have also a chance for conservative treatment. I try to look at the patient. I try to do a little bit of risk stratification and talk to the patient. If he really wants it fixed, and if he is someone in the high risk group, then I go for an acute surgery with the bracings in an anatomic way. If there's any doubt, I start doing physiotherapy with him. I know that I have these time frames of 3 weeks, 6 weeks to recounsel the patient and see how he develops. Usually these patients get on very quickly with conservative treatments. I think we are happy that Klaus Bach is not talking about the AC joint today, because he will tell us that all the conservative patients are very early, very back to action. So there's a lot of space for conservative treatment in this thing. So closing with our ESCA consensus, AP and panoramic view is also what we found with the ESA. Rockwood classification, try to add a little bit on it. Just don't look only on the X-rays. This is not a trauma surgeon thing. I think it's a more a functional problem. 3 weeks seems to be the cutoff for the chronic cases. And when you go for surgery, try to be anatomic and have less bone tunnels as possible. Thank you very much.
Thank you, Mr. Beitzel. I think it's better to have a couple of questions now and then go on with the next talk. So, are there any questions from the audience? Yes.
I'd like to ask if you're gonna give a patient the chance if he has an instability in 3B. For a conservative therapy. Work with 3B.
Oh, yeah. So a type 3, if it's 3B or 3A, starts conservative treatment. A 3 is for me, go for conservative. Only in very rare cases, a 3 needs surgery, but type 3 basically is ending up conservatively. And perhaps if we go down into the discussion of a type 3A, 3B, that's more what I try to say. It's a coper, non-coper. Perhaps the 3B, the non-coper, who is not getting away with it, is more horizontal instability, more type 4 at the end of the day, which we didn't pick up with the X-rays and didn't precisely document it like this.
Okay, thank you.
Any other questions? So Knut, if you have a patient with type 3 dislocation, you always send him for a specific physiotherapy protocol, because you mentioned that on 70% of such cases, they develop dyskinesia. Is it true?
Yes, so all of these Italian groups, when they looked at it, I mean, when we talk about type 3, we always have to be careful that this definition of a type 3 is a very broad spectrum. Everybody of us in the room will pick another type 3. It's very hard in the studies. If we try to present cases to consensus, we have done another consensus with the ISACOS group, very hard to have everybody agree on the instability grade. But yes, because I know that the problem is the scapula. I give them a sling for a couple of days. Usually after 5 to 6 days, they don't have so much pain anymore, and then they are free to use their arm. I tell them to not weight bear the arm for about 4 weeks, to not lift heavy loads, and I try to get them very early to the scapular setting and scapular training with the physiotherapists to get them the optimal treatment.
Okay, thank you very much.